So it really keeps us functioning every day. So in your Limon and Burke, there are some reviews of A and P in the beginning sections on the liver. You can look at those. I'm not testing you on it, but there are some things that we pull out of the A and P that relate to the diagnostics of the disease processes that we talk about. So the first one on your notes is hepatitis. You are all, for the most part, vaccinated for Hep B, so we'll talk about those in a minute. The definition is an acute inflammation of the liver caused by viruses, toxins, or bacteria. And probably the one that we're more familiar with would be viruses. Okay, so acute inflammation of the liver caused by viruses, toxins, or bacteria. So the various types. The first one is toxic hepatitis. For toxic hepatitis, this is going to be an issue from either drugs, alcohol, or some type of industrial agent, like a cleaning agent, some type of solvent, paints, those kind of things. 25% do come from drugs. And what particular over-the-counter medication can cause severe liver failure? Acetaminophen, right? Acetaminophen. So we have warning labels on anything that has acetaminophen in it. Percocets, you name it, if it's got acetaminophen in it, it's warning you, be careful of how much you consume per day, etc. Alcohol is another issue, and then industrial toxins. It is surprising that anything that you rub on your skin, inhale, ingest, are all detoxified by the liver. So when it says you need to be in a well-ventilated room to work with certain paints, you should do that. When it says you need to wear rubber gloves to do the cabbie wipes and those kind of things and wipe things down, you should do that. All of those chemicals are being absorbed or inhaled, and then they're detoxified by the liver. So I had a student, she's probably been out 15, 20 years now. Her sister was using a basic cleaning agent in her home and ended up in the ICU with acute liver failure from just the chemicals being absorbed through her skin. And it was nothing out of the ordinary. And I probably had used it millions of times without using gloves and those kind of things. But her sister was just very sensitive to the chemicals in it. And she did have her acute liver failure resolved. She did not have to have any type of long-term issues with it, but she definitely was in the ICU trying to get her liver healed and stabilized. So the best thing you can do for toxic hepatitis, these are all preventable types of hepatitis. We would monitor liver functions. We would use proper ventilation, masks, gloves, protective gear. There are hepatotoxic medications that people take. They are necessary for their life, but we would monitor their liver function while they're on them. One of a severe hepatotoxic medication that I can think of that people do take on occasion, especially younger in life, is Accutane. They take it for unrelieved acne that just is untreatable by all other means, and they take it for a short window, 6 months to a year, but while they're on it, they do have to have routine liver function tests done because it can be detrimental to your liver. So that's one that I can think of. Wild mushrooms in the spring, every once in a while you'll see the newspaper then that somebody has eaten wild mushrooms that were not edible, and it caused acute liver failure in the patient. Sometimes they end up needing a transplant from it. Never overdose on Tylenol or acetaminophen, folks. Never. Okay? It will destroy your liver. The only way you're going to survive is a liver transplant. I'm not an advocate for doing yourself in, but do not use acetaminophen because most of the time it only causes you severe damage. It does not cause your demise. So, not a drug of choice by any means. Nursing responsibility. Teach patients when they go home with medications that have acetaminophen in it, remind them. Now, you probably have other over-the-counter medications at home that also has that in it, so you need to be careful on how much you consume. Make sure that your kids, if they're doing chores for you and using cleaning products, that they're using a toilet wand or something for the toilet cleaners. My mother's old school. Get your washcloth down in the toilet and scrub that. Do not use some type of toilet brush. You do not get it clean enough. But yet you don't really want your hands exposed to the chemicals that you're cleaning the toilet with. Just good interventions, good education on how these things can affect you. All right. You mushroom lovers, those are good if you eat the right ones. Some people are like, another reason not to eat mushrooms. Mushrooms are delicious. I don't care what you say. All right. Viral hepatitis. This is probably the one that we are more familiar with, unfortunately, in healthcare. In this one, we are looking at some different things that happen to the liver when we are exposed to different types of viruses. What happens is we have hepatocyte damage. This is due to the inflammation that occurs. Okay, so hepatocyte damage is due to inflammation. The altered cell function will be dependent on the amount of liver damage that occurs. Okay, it'll be dependent upon the amount of liver damage that occurs. They have inflammation. We can have impaired bile flow, and they can have jaundice. And this can be due to the inflammation that's occurring, or they can have bile issues. So that impaired bile flow, when the bile cannot be released, it can cause jaundice. And our inflammation to those areas can also cause jaundice. So when those things happen, what results? Well, they have a decrease in their protein and fat synthesis. They have a decrease in their carbohydrate metabolism or synthesis. And their ability to detoxify agents, anything, also decreases. So their protein and fat synthesis, carbohydrate synthesis, and their ability to detoxify anything decreases. What happens to their labs? Well, these are liver enzymes. Their ALT and AST will increase. Their ALP will also increase. They'll have a prolonged PT, and this is due to a decrease in vitamin K production. They can have an increase in their serum bilirubin levels, and that would come from the impaired bile flow. They can have an increased erythrocyte sedimentation rate, and that's due to inflammation. And they can have a decreased albumin level, and this is due to a decreased protein synthesis. So a lack of protein in the diet decreases your albumin levels, and albumin is responsible for keeping fluid within the vascular space. So if you don't have enough albumin on board, fluid does leak, it gets into a third space, and it is not usable by the body. So what are some of their signs and symptoms? Well, most hepatitis patients follow the same similar course. There are 3 phases. Your book talks about them a little bit individually, but we're just going to talk about the 3 phases in general as they relate to hepatitis, not for specific A, B, C, D, or E of hepatitis. So in the pre-icteric phase, it usually is about 1 to 3 weeks, and this is before the onset of jaundice. They have a lot of GI symptoms. They complain of anorexia, they just don't feel like eating, nausea, vomiting, weight loss, malaise, arthralgia or painful joints, weakness, a lot of flu-like symptoms, and they can have mild right upper quadrant pain. The icteric phase, the second phase, usually begins with the onset of jaundice. This can last about 2 to 6 weeks. They can have right upper quadrant pain, pruritus, and that's just due to a buildup of bile salts under the skin, so their skin itches terribly. Light or clay-colored stools. They can have a brown urine, and that's from the bilirubin. And their pre-icteric symptoms improve or subside. So jaundice, right upper quadrant pain, pruritus from a buildup of bile salts, light or clay-colored stools. They're light or clay-colored because biles is what gives us color to your stool. So when it's blocked and it can't get out, the stools will actually be very light, or they'll look like clay coming out, the color of clay. They'll have little or no color to them. They're not greenish, they're not brownish.
Hey.
They really don't have any color to them at all. Oh, the other thing that I don't have on there is when we do have a buildup of bilirubin, it has to get to about 2.5, and when it gets to the level of about 2.5, you will actually see then jaundice within the sclera or the skin. And I saw a poor lady, she had gallbladder CA, and she had a bilirubin level of like 20, and she was like day glow green. Even the physician said he had never seen anybody that greenish yellow in his life. And I think the color that it reminded me of is if you've ever hard-boiled an egg and you've boiled it too long, when you crack it open, it has that greenish yellow color. That's what she looked like. So she had extreme jaundice. Post-icteric, this lasts about another 2 to 12 weeks. The jaundice does subside. Everything starts to look better except the malaise and their weakness. So that is one thing that our hepatitis patients do complain about, is that they just don't have much energy. In fact, sometimes they can't even get back to work for 6 to 9 months post this period because they're just not in energy to do it. So they look better in that post-icteric phase. And the last section is medical management. In this case, we're going to rest the body, we're going to give good supportive care, we're going to assist the liver to regenerate, which means no alcohol. Don't take any hepatotoxic medications unless they're necessary for life. We wouldn't be taking acetaminophen. We wouldn't be taking anything that works the liver harder. We wouldn't be using cleaning agents without our gloves on, those kind of things, okay? And then we don't really have any real diet restrictions with hepatitis. So here's a little bit of a grid, and I kind of redid it on your notes. So I would follow the grid on your notes. I even updated it really from what this is. But you do need to know the route. So the top line, the fecal oral route, blood and blood products, transfusions, co-infection, fecal oral. The next one I want you to worry about is the third column down. What do we give them if they've been exposed, and is there a vaccine we can give them prior to exposure? So column 1 and column 3 in the slide, and I forget how many columns you have on your notes because I've updated it from what I have in front of me, but the same thing, the preventative and the post-exposure treatments and the routes. The other things your book talks about, you would be able to look them up if somebody was diagnosed, about their antigens and those kind of things. So I wouldn't memorize those, but the other ones we do need to know. So for hepatitis A, it is a fecal oral route. So contaminated foods, contaminated waters, those kind of things are what we're looking at. The Havrix is the hepatitis A vaccine that they can get. And then if they are exposed, there is immune globulin therapy that they can also get. For hepatitis B, it is blood and blood products. We can give the hepatitis B vaccine, and if you have been exposed, there is the Hib Big, which is a post-exposure vaccination that they can get. And there is interferon injections that they can also take. For hepatitis C, they are primarily from blood transfusions, so people at high risk would be hemophiliac patients. It used to be a lot of our tattooing folks when they didn't have cleaning that was proper and they weren't regulated. We would see a lot of Hep C patients from that. There is no vaccine for Hep C. Interferon would be post-exposure, and now we have over-the-counter medications for those folks that they can take that will help with their post-exposure to hepatitis C. And I had on one of my notes, but I don't think I have it in front of me, the cost of taking some of those medications for Hep C, and they're in the thousands of dollars. They take it for around 3 months, and what it really does is it backs those markers, that hepatitis C marker, back into the cell, so they really never get rid of it. So they still can't do blood transfusions and those kind of things, but it will make it look like they no longer have Hep C. They have no more symptoms from their Hep C, and they're having very good results from it. But like I say, it is not cheap to go through it. It's thousands of dollars for a 3-month run of that. But when they're done, you hear people say, I am cured of Hep C. And so it is out there for folks. I wouldn't want to get Hep C just to say that I took the medication and was cured of it. But yeah, there are treatments now for Hep C out there. Delta virus is a co-infection with B, so it is blood or blood products. If you have immunity via vaccine to Hep B, you will not get the Delta virus. It is like the monkey on the back for this. And without getting Hep B, you can never get the Delta virus. E is a fecal oral. This is mainly third world countries. It is not necessarily, we tend to get Hep A in the United States. Hep E is fecal oral route, also tends to be third world. There is no vaccine for hepatitis E. There's no post-exposure for it. And the biggest risks are pregnant moms. Oftentimes there is risk of miscarriage and those kind of things when they have Hep E. All right, so you can look at those in your book too. It's kind of reduced it down, but that's just it in a nutshell, comparison of the 5 different types. So for nursing care, what do we do with our patients with hepatitis? Well, again, we want to provide rest. We want to do comfort measures. Pain medications we're going to use with caution. They shouldn't be in a lot of pain, but I can say that they can be driven nuts because of their pruritus. Think of the worst case of poison ivy, or if you're older, Perry, I hate to put you and I into a benchmark, but you probably had chicken pox. There was no vaccine at the time. There's no vaccine for me. But if you had a really bad case of chicken pox, you could just scratch and scratch and scratch at your skin because it just would drive you crazy. So sometimes your mother would put you in a tepid bath water, maybe an oatmeal bath, something to soothe the skin. We really wouldn't use a lot of soap on the skin. We would want to be in a cool environment. If you think of any time your skin has had a bad patch of poison ivy, when you sweat and you're hot, it makes it worse. So being in air conditioning, cool area would make your skin feel better. So think of comfort things that you could do that would be non-medication wise, but would be for comfort. Food, fluids, and electrolytes. The amount, about 3,000 calories a day, types of food, low fat. They're still the easiest to digest, carbs, those kind of things. Protein, we need some protein, but a lot of protein is harder for us to digest. Daily weights, we're watching for fluid retention, possibly abdominal girths. We already talked about how to measure that. And then antiemetics. 3 antiemetics that are probably out on the market that we're most familiar with are Zofran. We give that a lot because it has very few side effects. Phenergan. Phenergan is great when you give it in combination with other pain medications. It does tend to make you sleepy. Compazine has a few more side effects, but all 3 of those can work very well for the patient. Number 4, monitoring for possible bleeding. So monitoring their PT, PTT, their H&H, looking for occult bloods. Number 5, isolation. We just use enteric isolations. If we use good fluid precautions, we really do not need to put a hepatitis patient in isolation anymore. We are very careful with our hep patients, especially our hep Bs and hep Cs when we're starting IVs and working around their blood. But for the most part, if we just use good precautions, we are secure from that. Patient teaching, no alcohol, avoiding over-the-counter medications because again, they're all broken down by the liver. We want to observe for signs and symptoms that their condition could be getting worse. And we do follow-up labs for 1 year after they return to normal. So if Heather has Hep A and she's recovered from it and all of her liver enzymes are back to normal, her doctor will monitor for up to 1 year. If Heather has an outlier, one of her liver enzymes is chronically elevated for another 6 months to 9 months, but all the rest of her symptoms are gone, she still will be monitored for another additional year after those enzyme or after her liver function tests go back to normal. Okay? If it takes 2 years, she'll be 2 years plus 1. All right, so that's how it works. Complications. So on your little grid for your A through E, there are some complications that can occur with our patients when they get hepatitis. The first one is chronic active hepatitis. This is where the liver destruction occurs, and this is with Hep B and C. A third of those patients will develop cirrhosis, and they are at an increased risk of getting primary liver cancer. So chronic active hepatitis, this is where the liver's destruction continues. This is with B or C. They can get cirrhosis in a third of the patients, and they are at risk for primary liver cancer. So this is chronic active hepatitis, CAH. The second type is chronic persistent hepatitis, or CPH. Again, this is in Hep B or C. The liver damage does not progress. This is where they're often asymptomatic, but their labs are either normal or they have a mild AST and ALP for up to an additional year. So instead of getting better in 6 to 9 months, these people might be 12 to 16 to 18 months. And then remember, once they go back to normal, they're still going to be monitored for an additional year. Our third type is fulminant hepatitis. This affects there's about a 75% mortality rate if you get this type of complication. It occurs within about 6 to 8 weeks. There's a failure of the liver to regenerate, meaning you keep getting sicker and sicker. Necrosis of the liver is usually beyond repair. Death often occurs because what has to happen here is they have to have a liver transplant to survive, and oftentimes the liver does not come available to them quick enough. This does happen with Hep B that is concurrent with the Delta virus. So the higher risk is if you get Hep B with the Delta virus. So this is why we really do not want to get Hep B to begin with, because we don't want to take a chance that we would acquire Hep D, and their risk of major complications is quite significant for these patients. Okay. So prevention. So I found, it was on the next page here. So the cost, remember I talked about getting rid of Hep C, $94,000 for 12 weeks. That's your cost. There is no blood donation ever. And how it works is it pulls the virus into the cell so that it is not detectable. I knew it wasn't cheap. I knew it was thousands of dollars. I didn't quite realize it was close to 100,000, but that's a big chunk of change for our Hep C patients. Hep B, vaccination. Cost about $100 or so. It's 3 injections within so many months of each other, and then the efficacy is 80 to 95%. Hep A vaccine is the Havrix. It's an attenuated live virus. It's a 2 injection dose. Who should get it? Well, if it's fecal oral water contamination, it should be people that do home renovations, where they're pulling toilets and showers and those kind of things. Water treatment plant workers. If you do mission work, third world countries, and you might come across contaminated waters. If you are a daycare provider and you watch other people's children and you're changing diapers and those kind of things, you should have a Hep A vaccine. So lots of good reasons to have a Hep A. I believe Nathaniel, my oldest, is 18 and Audra is 15, and they were given Hep A vaccinations as children. That was part of their vaccination protocol, was the Hep A series. So they already have that. So most of you may have some of that, and if you have small children, your children may have Hep A vaccines already. They are highly recommended by the pediatrician. Then thirdly on that is the Twinrix. That is a combination of Hep A and Hep B. It is a 3-series injection that they dose out the Hep A with. So those are available at your health department and probably in your pediatrician's office for the Hep A. All right. As you look over that, your book does have a pretty good section on hepatitis. So if you need clarification on anything, go ahead and read in the book. If you want to add something to your notes, for clarification, you can also do that. And then if you still have questions, let me know by email or let me know next week. Our next disease process for the liver and our final one that we will talk about is cirrhosis. And when we talk about cirrhosis, we're going to talk about several causes. But once we get past the first page of notes, all of the cirrhosis that I will be talking about will be either alcoholic or Lanic cirrhosis. It's alcohol causative. There are some other causes of cirrhosis, but the one that we're going to talk about is alcohol related. So for alcoholic or Lanic cirrhosis, this is the most common type of cirrhosis that we deal with in healthcare. The causes are drinking a pint of alcohol or more per day for greater than 10 years. Malnutrition is the second causative factor. So when we say a pint of alcohol, we mean hard liquor for that. For beer consumption, it would be like consuming a 12-pack a day. Now, if I told you that you were going to drink 12 Pepsis a day, would you be hungry? No. Isn't that the whole premise of like Weight Watchers? Drink a glass of water when you wake up, drink it before you eat a meal because you'll fill up and you won't be as hungry. If you were drinking 12 Pepsis a day, I bet you would not be very hungry. You might eat a little bit just to eat, but you're probably not hungry. So if you're consuming 12 beers a day, I guarantee you that you're probably not consuming a lot of extra nutrition. Your food is very liquid. There are some stages that our alcoholic cirrhosis patients go through, and the first is cell degeneration with fatty infiltrates. The liver increases in size, and it increases the amount of WBCs that the body will produce. If at this point you are able to control your liquor, meaning you probably don't need any, and you improve your nutrition, your liver will regenerate, it will heal itself, and it is reversible. Okay, so if you can not drink alcohol, you can improve your nutrition, your liver will regenerate, it will heal itself, and at that point, it is still reversible. Our second stage is our late stage. This is where the liver forms scar tissue. It becomes fibrotic, necrotic. It decreases in size, and it becomes nodular in nature. And this is all due to alcohol use. So scar tissue formation, fibrosis, necrosis, the liver now starts to decrease in size and it's nodular in nature. At this point, there is no turning back. You would have to go into therapy for alcoholism. You would have to prove that you are no longer drinking or want to drink, and then you would be able to be put on a liver transplant list. So in the fatty stage, it is reversible. In the late stages, it is not. Okay, so our another type are post-hepatic. So we would have some type of toxic or viral hepatitis that could cause us to have cirrhosis. The liver enlarges and then decreases in size. It can become nodular in nature and decrease in functioning. So we know there are other causes of cirrhosis out there besides alcohol abuse. There's also biliary chronic bile obstruction can cause permanent scarring. The bile stasis within the liver causes the liver to fibrose, causes liver damage. And in this particular case, jaundice is its key manifestation. So far we have alcoholic cirrhosis, post-hepatic from viral or toxins, or even autoimmune. And we have chronic biliary obstruction that can cause problems. I do have one more, and didn't think I took it out. Let's go the other way. Do I have a letter D on your notes?
No.